I don't see our videos. 1 second, let me load them again.
Yeah, get rid of that poster.
Well, good morning, everyone. This is Terrell Eisinger. I'm the Executive Director of the National Organization of State Offices of Rural Health, and I hope that I'm the first one to wish you happy National Rural Health Day today. This is the first in a series of short websites and webinars that we'll be offering this morning. I want to get right to the business of the day and to thank our federal partners who join us in our efforts to recognize the hard work of rural leaders and rural providers and the state offices of rural health around the country as we celebrate National Rural Health Day. This topic, our first webinar of the day, is very important. As you all know, it takes a heavy lift in collaboration, working together between federal, states, and local communities to improve healthcare and improve the health of our rural people. We could not do this work without a federal partnership with the Center for Disease Control, the CMS, and certainly the Federal Office of Rural Health Policy, and HRSA is an anchor of all resources and information related to rural health. So I'm going to hand off to Tom Morris, and thanks to you and your staff at the Federal Office of Rural Health Policy for joining us today.
On National Rural Health Day, I want to offer a big thank you for all that you do on behalf of our country's rural communities. And a big thanks to Terrell and others with the National Association of State Offices of Rural Health and HRSA's Federal Office of Rural Health Policy for bringing the country together to celebrate the important things that are happening in the area of rural health. As you know, HRSA works directly with local communities and states to improve health by supporting access to quality preventive and primary care services, building a skilled workforce, and developing innovative programs. And rural issues are front and center for much of HRSA's work. In fact, our Federal Office of Rural Health Policy plays a critical role with two distinct but complementary functions within HHS. First, they advise the Secretary on rural policy issues across the department, and second, they administer a number of grant programs focused on supporting and enhancing healthcare delivery in rural communities. By locating both functions in the same office, the Federal Office of Rural Health Policy is able to use its policy role to inform the development of grant programs and its grant programs to help ground its policy focus. This is very important to stay grounded in what really works in rural communities. And one thing that we know is particularly challenging is the recruitment and retention of a qualified workforce in rural communities. HRSA continues to look for ways to use our workforce programs to strengthen physician residency programs and encourage more providers to work in rural communities. We also know that exposure to primary care in rural areas during their training means that people are more likely to end up practicing in primary care and serving in a rural or underserved communities. And that's why the Rural Training Track program is so important. It supports family medicine residencies, and it has grown. In fact, it has nearly doubled to 42 programs since 2011. In addition, the Teaching Health Center Graduate Medical Education programs helps to increase the number of primary care and dental residency programs in rural areas. In fact, almost 50% of Teaching Health Center grantees now train in rural communities. And of course, the National Health Service Corps program places providers in rural and underserved communities across the country by supporting scholarships and loan repayment. Last year, there were over 2,100 core clinicians serving in rural communities, with an 88% retention rate after 2 years. We also support the National Rural Recruitment and Retention Network, 3RNet, which placed more than 2,000 clinicians in rural areas. Now let's talk a little bit about service delivery and the different programs within HRSA. As many of you know, health centers play a critical role in ensuring access to primary care in rural communities and is one of our cornerstone programs. Close to 47% of the 9,800 service sites around the country are located in or are serving rural communities. HIV has increasingly impacted rural communities, as witnessed last year in rural Indiana with the increasing use of opioids. And through our Ryan White programs, we are increasing our footprint and response in rural communities nationwide. We're also expanding our rural services to mothers and children. Just last year, HRSA's Federal Home Visiting Program provided voluntary, evidence-based services to new moms and kids in more than 400 rural counties. And thanks to new technology, especially telehealth and health information technology, we're helping to ensure greater access to specialty care in rural areas, especially behavioral health services. However, we also know that there are challenges taking place in rural communities. Since January 2010, nearly 80 rural hospitals have closed. And HRSA is closely tracking these closures to better understand the factors behind it, but even more importantly, the assistance that we can provide to rural communities. Just recently, we awarded $2.5 million in rural health network planning grants to communities that have either lost their hospital or are at risk of losing their hospital. We're focusing in particular on what future healthcare and hospital care should look like. And we're working with our federal partners based on your feedback to assess what those new models of rural healthcare delivery should look like. HRSA is also working on a toolkit and resource compendium to assist state offices of rural health who are working with vulnerable hospitals and communities. All across the department, we're looking to find better ways to deliver care, pay providers, and share and utilize information. It's crucial that low-volume rural and safety net providers, whether critical access hospitals, rural health clinics, or health centers, fully participate in the healthcare delivery system of the future. HRSA is committed to work with these providers and our federal partners to find a way to make this happen within the framework of the special payment systems that are designed to maintain access for vulnerable populations. In closing, I want to congratulate you again on National Rural Health Day, but more importantly, thank you for what you do every day to make rural healthcare better for millions of people across this country. Thank you.
Okay, this is
Tom,
Tom Morris. Go ahead.
Yes, thank you, Tom. I appreciate that. This is a great example of federal and national and state collaboration. Who's on first? So, Tom, you're up next, and thank you for joining us today.
Thank you, Terrell. And I'm happy to join the webinar and want to thank the state offices of rural health for really being the driving force behind National Rural Health Day. It never would have been created without their efforts, and each year it keeps getting bigger and better. And I think Jim McCrae, the acting HRSA administrator, just did a great job of summarizing, I think, not only the work we do in the Federal Office of Rural Health Policy, but more broadly the impact that HRSA programs and resources have on rural communities. So I'd like to take a little bit of a leap off of that and talk a little about some of the challenges that we see in rural communities. For the last couple of years, we've really been intrigued by some of the data that's emerging around life expectancy and mortality in rural communities. There's been a national discussion of this triggered by some research done by Deaton and Case out of Princeton, but it mostly talked about at the national level and focused more on gender and certain regions of the country, but didn't really get into the rural-urban angle of it. And yet I think this is one of the most compelling disparities we've seen emerge in the last 20 years. And so if we go to the next slide, I really take my hat off to my colleague in HRSA, Gopal Singh, who back in 2013 published some articles in the academic literature that really brought a needed attention to this from a rural-urban angle, and sort of built on some of the work that we saw from Deaton and Case. And I think it's best illustrated by the next slide, where you can see for many years, life expectancy was tracking similarly for rural and urban areas, but you started to see a gap around the late 1980s, and it became more pronounced as we went into the early 2000s. And we're really seeing that those lines diverge even now. And so, to me, this is a very compelling issue and it's been a framing issue for us to talk about. And there are a variety of reasons that are driving this. If we go to the next slide, I was happy to see the Robert Wood Johnson Foundation folks in their county health rankings really pick up on this issue, and I thought that brought needed attention to it, but we haven't seen a high-level national attention to this that I think it's deserving of. And so I do think that we shouldn't be surprised by what's driving it. If you look at the next slide, obviously, the opiate crisis over the past year is one of the driving factors. We know that drug-related deaths are higher in rural areas. We know that the risk factors are higher in many rural communities, and this has really devastated a number of small towns and regions of the country. But it's not the only factor here. If we look at the next slide, you can see that in a lot of ways we shouldn't be surprised at all by the fact that we're seeing these gaps in life expectancy and mortality. When you think about the fact that there's higher rates of chronic disease, higher rates of suicide, rural residents are more likely to smoke, we have higher rates of poverty, lower educational attainment. When you consider this in the broader discussion of social determinants of health, it sort of makes sense in a lot of ways. So addressing this challenge is certainly one of the things we're focusing on in the Federal Office of Rural Health Policy, and will be sort of a centerpiece for us moving forward. But I think you can also see other efforts across HHS that are underway that I think will help us understand these issues better, and also help us target our resources better moving down the line. So with that in mind, I'm happy to be joined by some of my HHS colleagues. You're going to hear from Dr. Kara James from the Centers for Medicare and Medicaid Services, Dr. Chesley Richards and Dr. Charlotte Kent from the Centers for Disease Control, and then Heather Damaris from our office will wrap things up and talk about a HHS effort looking at child poverty and healthcare called Rural Impact. And then we'll have time for questions and answer after that. But just a final nod to Terrell and all the state offices of rural health for really giving us a day, once a time each year, to really focus on rural issues and bring attention to these, what I consider to be really important issues. So I'll turn it over to our other speakers.
Thank you, Tom, and good morning to each of you. My name is Kara James. I am the co-chair of the new CMS Rural Health Council and the director of the Office of Minority Health here at CMS. And I'm pleased to join you this year on National Rural Health Day to talk about some of the efforts that CMS has underway to improve health and access for rural communities. And first, I also would like to thank Terrell and those at NOSOR, as well as our colleagues at HRSA, CDC, and other federal agencies for their collaboration and partnership in our work to improve health outcomes. So earlier this year, for those of you who may not be aware, CMS established a Rural Health Council to focus on 3 areas: improving and access to high-quality health care for all Americans in rural settings, addressing the unique economics of providing health care in rural America, and bringing a rural health care focus to CMS health care delivery and payment reform initiatives. This effort builds on a number of activities that have already been underway in terms of CMS, so it's not necessarily a new focus, but it really is an effort to help coordinate and embed that focus across the work of the agency. So far, we've focused a lot on stakeholder engagement, but also thinking about how we can have a more coordinated effort in our policy development process to embed that lens of rural needs and the understanding the unique needs of rural communities. Tom laid out a number of those challenges already, and we are focusing on what we can do to improve those health outcomes. But as I mentioned, that strong focus of the embedding and building on that foundation of things that have already been existing, CMS has regional rural health coordinators in each of our 10 regions who are liaisons to you and the communities that you serve to help address challenges, and they have been there for a while. But also this year you saw a focus in improving access to primary care through our physician fee schedule, which was just finalized in the past couple of weeks. And this rule finalizes primary care policies to improve how Medicare pays for services provided by primary care physicians and other practitioners for patients with multiple chronic conditions, as well as mental and behavioral health issues and cognitive impairment. These changes will help improve payment for clinicians who are making investments of time, resources, to provide more coordinated and patient-centered care. For example, some of the things that we have in terms of creating new codes to separately pay for chronic care management and transitional care management services. And the agency solicited public comment on additional policies that the agency could pursue. Taking in all of that feedback, what we finalized is to make separate payments for certain existing current procedural terminology codes describing non-face-to-face prolonged evaluation and management services, to revalue existing CPT codes describing face-to-face prolonged services, separate payments to use a new code to describe comprehensive assessment and care planning for patients with cognitive impairment such as dementia, and making payments using new codes to pay primary care practices to use interprofessional care management resources to treat patients with behavioral health conditions, as well as codes describing chronic care management for patients with greater complexity. Additionally, a focus of telehealth and some of the advances of what we can do, we finalized several codes to list of services eligible to be furnished via telehealth. These include end-stage renal disease-related services for dialysis, advanced care planning, and critical care consultation furnished via telehealth. And we're also finalizing payment policies related to the use of new place of service codes specifically designed to report services furnished by telehealth. As Tom mentioned in some of the challenges in terms of chronic care management and chronic diseases that we see in burdens in rural communities, this rule also finalized the expansion of the Diabetes Prevention Program model test. And that model finalizes the policies to be eligible for Medicare beneficiaries. This is an area where we estimate that Medicare spends approximately $42 billion in a single year just this year for fee-for-service, non-dual eligible, and those over 65 with diabetes, costs that are significantly higher than those individuals without diabetes. Additionally, to the payments in the fee-for-schedule rule that we have, we also saw within our Innovation Center a number of programs that have been focusing on how do we help support rural providers to participate in innovative models, such as the Transforming Clinical Practice Initiative, which has a rural-focused, practice transforming network, as well as our Comprehensive Primary Care Plus model that includes a number of regional areas and states that have large rural populations, such as Montana, Oklahoma, Michigan, Colorado, Oregon, and Tennessee, and the new Quality Payment Program, which includes technical assistance for rural, small, and underserved providers to help them be able to participate in our rural model, in the efforts that are coming through innovation. Throughout all of the work that we're doing with the CMS Rural Health Council, stakeholder engagement has been at the foundation of it, and making sure that we're listening to communities to help inform the work that we're doing and to understand where we can do more. Just last month, we had our CMS Rural Health Solutions Summit, And as you can see in the top left corner there is my co-chair, John Hammerlin, who is the Seattle Regional Administrator for CMS. But this featured sessions that included a panel with our CMS center directors to talk about some of the activities that are happening within each of the centers around rural health, as well as a spotlight on local innovative practices, and very good and rich breakout sessions that we had discussion focusing on the essential health services that we need to preserve in rural communities, as well as telemedicine and what we can do to spur innovation. We're building on the learnings from that session and going out into each of the regions to engage with stakeholders to drill down and understand what we can do, as well as to look towards what a vision of rural health looks like in the next 10 years. This afternoon, we'll be in Carson City, Nevada, talking to stakeholders and kicking off those regional listening sessions, and they'll continue into January. From there, we'll be spotlighting and building on what we can have learned and thinking about how do we develop a plan moving forward. One of the other things that I wanted to highlight as we talk about the importance of chronic disease and just to show you the disease prevalence within Medicare. And you can see for the counties on this picture, we have Georgia and South Carolina. The counties with stripes are those that are urban counties, but you can see for the darker counties a higher prevalence, and a number of those are rural communities, problems that we see in terms of that chronic care management. And one of the things that our office is doing in collaboration with the Federal Office of Rural Health Policy is to be launching a chronic care management campaign. And this campaign is building to help inform providers and consumers about the benefits of chronic care management services for individuals with multiple chronic conditions, and focusing on encouraging participation, in particular in underserved rural populations, as well as racial and ethnic minority populations. This will be something that we're developing now and will be launching in the new year. But there's an opportunity for you to help educate us and inform us in this process. So if you would like, in the next couple of weeks on November 30th, we have a listening session that is going to be able to hear and solicit feedback. So we encourage you to join us for that and spend a little time with us. And finally, if you would like to learn more about some of what we're doing, we encourage you to reach out to the CMS Regional Rural Health Coordinators, as well as to join our Open Door Forum calls. These happen about every 6 weeks, and they are an opportunity where we take the time to update you on policy changes and programmatic issues, as well as take questions from you. And the link there at the bottom is where you can sign up both for the Open Door Forum calls, the Open Door Forum listserv, and where you can find a list of who your specific regional rural health coordinator is. And thank you, and look forward to hearing from you and to questions. Thank you.
Okay, we're going to turn it over to our colleagues from CDC.
Hi, this is Chesley Richards. I'm the Deputy Director for Public Health Scientific Services at CDC, and I'm joined by Dr. Charlotte Kent, who is the Executive Editor of our lead journal, the MMWR. Thank you for having us, and happy Rural Health Day. CDC, as you may know, is the nation's prevention agency, and we work with our other federal, state, local, and public health partners to protect Americans from health and safety threats, both foreign and domestic, 24/7, and to increase health security in the nation. We have a broad set of data and public health activities, particularly focused on health and healthcare disparities, but as an agency, we've never taken a specific focus on rural health, and that's changing in January. MMWR, our lead journal, which has 250,000 subscribers and 22 million web page views per year, will be launching a series of articles on rural health using the data we have at CDC and some of our programs. The initial papers will be on leading causes of death in non-metropolitan and metropolitan areas from 1999 to 2014 and disparities in the 5 leading causes of death in rural and urban United States. And we hope that these sets of articles will bring more attention to issues in rural health. In the coming year, the additional articles that will be published will consider topics such as healthy behaviors in rural areas, healthcare disparities, childhood mental and behavioral disorders, teen pregnancies, agricultural worker health and safety, environmental exposures, suicides, motor vehicle deaths, seatbelt use, and has been mentioned the growing epidemic of opioid drug overdoses. We'll be working with JAMA, as we have with previous articles in MMWR, to publish a JAMA viewpoint article with some of the MMWR time to go out about the same time as the MMWR articles. And we, again, hope that this series will highlight some of the challenges, but also some of the opportunities in rural health. We really appreciate being on the call today, and we are looking for collaboration with those who are interested in rural health. Thank you.
All right, and last but not least, before we get to questions, this is Heather Damaris, and I just wanted to top off the webinar on this collaborative kind of work around rural health to announce the release of a report that highlights a collaborative effort around reducing rural poverty through providing coordinated health and human services for both children and parents. The partners in this project were just unprecedented. It was across all of HHS and the federal government, including agencies such as HRSA, our office, Federal Office of Rural Health Policy, the Maternal and Child Health Bureau, Agency for Children and Families. The list goes on. But what's important to know is that this report was done through the Assistant Secretary for Planning and Evaluation, ASPE, at HHS, and it summarized key findings for the demonstration project titled Rural Impact. The summary does include a scan of all 10 demonstration sites and a more in-depth study of 6 of those sites. And if you're interested in knowing the 10 sites, they're rural and tribal sites in Arkansas, Iowa, Kentucky, Maine, Maryland, Minnesota, Mississippi, Ohio, Oklahoma, and Utah. The report can be found on ASPE's website, aspe.hhs.gov/reports. And I just want to take a moment to congratulate the 10 sites. If folks on this call are on or if they know these sites, they really have worked really hard over the past year to collaborate with partners they wouldn't have usually, and they really did have an impact on the communities they work with. So just congratulations, and if you're interested, please look for that report.
Okay, Matt, I think that's it for us in terms of formal remarks. So we could probably now open it up for questions if folks have any.
Yes, thanks, Tom. Just a reminder to folks that as you're tuned into the webinar in the upper right-hand corner, you can use the Q&A feature or the chat feature to send a note or a comment, and we'll watch those for you pretty quickly. And so take that opportunity to do that. And as we're waiting for those comments and questions, I'd like to thank all of you for that work. And if people could come away from one thing that you want them to hear from your agency today, I was taking a great deal of notes of follow up on this and follow up on that. If there's one thing that you want them to remember, and I'd go back to each of the panelists, please, what would that be? What's one thing to remember as they're going forward with their work in the future and linking with the resources that you have? Perhaps, Heather, you were last. If I could go to you first.
Sure. So I think the one thing, if I understand the question, that we could do to continue some of the efforts in collaborating is really the webinars like this, I think, that we've done through our office or NOSOR and other partners, keep those connections. I don't think that it's easy for large organizations to connect, but it is what rural communities do all the time, every day, because they're right next door to each other or in the same place. And so you can drive down the road a little ways to find your partner in a small rural community. I think in a really large bureaucracy, it's tough to do. So I think moving forward, that's one of the biggest missions I have, and I think we will try to keep up in our office.
Thank you, Heather. Kara, would you like to chime in about that?
Sure, and if I might, I might have two things, and I think one of the key takeaways is something that one of my colleagues said at the Solution Summit that we had, and I think that what we want people to know is that CMS is listening, that we have a lot of people who are very interested in what we can do to improve health outcomes in rural communities across the country, and our doors are open, and so we're doing a lot of stakeholder engagement, but we encourage people to share the feedback with us because we don't have all of the answers, and we are trying, but we need the input and collaboration of folks across the country. The second thing, I think, is just really that how much interest and enthusiasm there is within CMS to focus on these issues. I often talk about our Rural Health Council more like a rural health community because we had so much interest in terms of people who wanted to be part of the council. And so I think that that would be another takeaway, that there are a lot of people within the agency who are invested in these issues, and the work will continue until we are able to achieve those health outcomes we're looking for.
Thank you for that. I know that we have really appreciate the opportunity to make the comments, try to keep up with you, and try to keep rural issues in the forefront. Chesley, could you chime in from the resources from the CDC?
Sure. I think I'll also have 2 points. The first, from our perspective, is to really more effectively have awareness of the data that's relevant for rural health, particularly around the disparities that exist in health and health care. And I think the other point would be to really look for those opportunities where health departments working with other state, local, federal health agencies can address some of the disparities and some of the health challenges through new opportunities. So new partnerships, new relationships.
Thank you. I mean, we're very much looking forward to seeing the reports that you're coming out and appreciate the deeper research and look forward to responding those to you also.
Terrell, this is Tom, and I know you already heard from Heather, and the only thing I guess I'd add is for folks listening is it's important to realize, that while, we focus on rural because that's what we're statutorily required to do, and that's why we're created. The effort at the HHS goes much broader than that, and I think Jim did a good job of explaining it in his video from her perspective. And CDC has vast resources that go into rural communities, and they're doing this MMWR series because they want to. That's an effort that they saw an opportunity in. Similarly, with Kara's work at CMS and the Rural Council, again, they came up with that as a way to, think about different ways to improve or enhance their interaction with rural communities. So I think across the department, you're seeing some important efforts about better understanding the issues in rural, either through data analysis or listening to stakeholders. Or in some cases, it's targeted initiatives like the one Heather talked about that take into account the unique characteristics of rural communities. And I would venture to say that we could probably, loop in another dozen or so of our colleagues from across HHS and talk more about specific projects where some interesting things are going on. Even with the transition, we expect those efforts to continue, and there'll be new ones to talk about in the coming year. So I'll probably just stop there.
Great. Let me feed you. I couldn't agree more, Tom. Let me just feed you at least one. Try to grab any questions or chat out of the Q&A. Sue Pearson asked, and this is a great opportunity to make a plug for a couple of rural resources, but Sue Pearson asked, is there a website to check whether a clinic is rural or urban? Tom, would you like to field that?
Sure. On our website, there's a lot of definitions of rural out there, so we could spend a whole 4-hour webinar just on that, but we won't. But on our website, we do have a tool under our grants eligibility page where you can find out if you're rural, and what we use as a definition is the standard county-based OMB definition of metro and non-metro areas. So that would include micropolitan and non-core based statistical areas. And then we also use the rural-urban commuting area codes that classify census tracts as rural or urban. And so when you plug your information into our tool, it would tell you whether you're rural by that standard. And if anybody has other questions about, variations of those definitions, Steve Hirsch from our staff is sort of the definitional guru and would be happy to walk folks through that. And they can just call the main number at 301-443-0835 and connect them to Steve. But start with the tool, and then we can go from there.
Thank you. I don't see any other questions or chat in the chat. Folks who are on the line feel very comfortable to use the Q&A and the chat. Anything else from the panelists that you'd like to add?
No, I think we've covered it, and just stay tuned for more, because I think as Kara talked about, there's efforts underway with CMS in terms of the listening sessions and the MMWR series, which we're really anxiously awaiting and looking forward to working with our CDC colleagues on that. And then the host of other webinars you have on today, and I guess I'd put a plug in, selfishly speaking, for our telehealth demo today at 2:30. We talk about telehealth as an important tool for enhancing access, but also improving outcomes. And so today you could take part in that and see how it's done. We have a Vera Health system in South Dakota that's going to give us a demonstration. And there's also, they just signed a contract with the Indian Health Service to do some innovative work in the Upper Great Plains area. So more to come today, and more to come in the ensuing months. And then finally, I would just say thanks to NoScore again for hosting this webinar and giving us a chance to talk about our efforts here at the department. And then you can just go to HRSA.gov for more information about our programs, and Terrell or I can link you to other parts of HHS if questions or issues come up.
Thank you, Tom. So Cassie or Matt, do you see any other questions in the Q&A or the chat? I do not.
I got one privately as the host. Will the MMWR consider rural health papers from non-CDC investigators?
So this is Charlotte Kent, and I think that that's something that we could consider, and I think if there are no CDC authors on it, well, everything that's published in the MMWR has to be cleared at the highest level of the agency from a science perspective, and so any papers that are that include only non-CDC authors would have to be cleared by the agency. But I think that that's something that we could consider, and what I suggest is if there's anyone who's interested in that they contact me, and my email address is C as in Charlotte, K-E-N-T, so Kent @cdc.gov. And then I'll also have some discussions internally about that, so we can respond in a timely fashion. Thank you.
Thank you. I would just say that I think that it's important for rural communities to always try to make a linkage to their universities and to their land-grant institutions that really have a responsibility for outreach around the nation. I think that there are some great opportunities to link up with academics who are qualified principal investigators and publishers, and we want to help build those connections as we're approaching topics like that. Here's another question from April Crago. What is the status of FQHCs being recognized as distant site providers for telehealth? Let's see. Tom, you're a great generalist and policy resource for that. Would you like to take that, or shall we refer back to telehealth resource centers? Would you like to comment on that? Anyone on the call?
I can, it's obviously a CMS question. As I remember it, it's a legislative issue, this statute. It may be a statutory issue that precludes that, but maybe Kara knows more.
No, I think you're right on that, Tom, and that's I don't have anything else to add to that at this point.
Thank you. There are some telehealth resource fact sheets on the National Organization of State Offices of Rural Health website under educational resources about telehealth in general, and certainly the session that is planned for later today is a great demonstration and, a clarification of how those partnerships put together to provide telehealth resources. Anyone, I don't see anything else in the chat. I'll double check to make sure that Matt or Cassie did not get private questions.
I'm good.
No, I think we answered everything.
Okay, that's great. So as we're signing off, I hope that you all will find the information about the webcast that Tom mentioned. You can find that on the NOSOR Facebook page, and I'm sure there are other places where you'll see that. So please plan to tune into that later today. There are also other short webinars that are planned for later in the day, so I hope you'll check our website for that. We hope that you're active on social media, and we'll continue to use the hashtag Power of Rural. How about posting what you love about rural America and rural health and using the hashtag Power of Rural. Before we let you go, this year we are trying to make sure that people understand the importance of continuing the work throughout the year. So our friends at Impact Communication have prepared a great tool to ask you to pledge to support rural health. And Cassie's going to play a little bit of a video for you about that, and afterwards the information and the link to the pledge will pop up. I thank you all for joining us, and thank you again to all of our federal partners who made National Rural Health Day a group effort today. Thank you.
Thank you for joining us in celebrating the power of rural. My name is Michelle Rathman, President of Impact Communications, and it has been an honor to work with the National Organization of State Offices of Rural Health to increase the outreach and awareness of National Rural Health Day 2016. As a part of our efforts, we've helped to develop the Pledge to Partner. It is now my pleasure to introduce this important initiative to all of you. The Pledge is a way for us to transform National Rural Health Day into a year-long, ongoing commitment to bring collective focus to specific healthcare issues facing rural communities across the United States. We're asking you to begin new conversations about the power of pioneering partnerships, and we need all rural health stakeholders to inspire communities across the country to address and resolve their most challenging population health issues. The Pledge to Partner focuses on 4 key areas, and these are: first, innovation. Commit to developing ideas, programs, and models that continue to transform and positively impact rural healthcare delivery. Challenge partners and community leaders alike to explore new approaches to reach at-risk rural populations, and engage thought partners from non-healthcare industries to help create additional solutions to prevailing health challenges. The next area of the pledge is focused on education. Initiate frequent discussions designed to inform stakeholders about the real issues facing rural providers. Inform those entering the field of medicine about the great and fulfilling opportunities to care for rural communities, and share facts and information about the needs to improve access and outcomes with those who influence policy and the allocation of resources. The next area of the pledge is about collaboration. Commit to forging new relationships that will bring additional resources into the rural healthcare fold. Please invite competitors to become those thought partners, helping to find synergies that result in achieving important shared goals, and then share ideas and resources and information with industry and non-industry contacts, seeking ways to work together in the common interest of rural health and wellness. The last piece of the pledge is all about communications. Use all available channels and mediums to spread the word about the power of rural. Follow, like, forward, post, and pin those stories and ideas and facts and opportunities and partner with all of those who are working to make a difference in rural health care. We're also asking you to really stay connected with NOSOR and your state offices of rural health throughout the year and help us reach the goal of 1 million people in social media platforms leading up to National Rural Health Day 2017. So there you have it. The 4 major areas of the pledge is to innovate, educate, collaborate, and communicate. And it's very easy to take the pledge by visiting powerofrural.org. There's a very simple form for you to complete, and when you hit the send button, you'll start to receive information for the rest of 2016 and into 2017, leading up to National Rural Health Day 2017. And the last thing we're going to ask you to do is, in everything that you do today with social media, please use the hashtag #PowerOfRural. Thank you so much for the opportunity to be a part of National Rural Health Day 2016.
That concludes our webinar. Thanks, everyone.